This is Andrew Paul Cronin, and you're listening to the Q&A with A.P.C., the show that features conversations with artists, cultural figures, policymakers, performers, and other innovators living in Virginia. Episode 31, Dr. Cynthia Romero. My guest, Dr. Cynthia Romero, is a physician and the current director of Eastern Virginia Medical School's Brock Institute for Community and Global Health. Throughout her career, she has held nearly every job a doctor can have and has been a pioneering woman in medicine and an advocate for her patients and for the medical profession. In 2011, she became only the third woman in 191 years to be named president of the Medical Society of Virginia. In January 2013, she was appointed by Governor Bob McDonnell as Virginia State Health Commissioner. As commissioner, she was responsible for nearly 5,000 employees, 119 health departments, 35 health districts, 41 separate service areas, and an annual operating budget of $626 million. To put it more simply, she was essentially the Doctor of Virginia. This episode of the Q&A with A.P.C. was recorded at the Slover Library in Norfolk, Virginia. Dr. Cynthia Romero, thanks so much for coming on the show.
Andrew, good to be here.
Your mom was a doctor growing up.
Yes, yes.
Was it expected that you would become a doctor, or did having a mom for a doctor influence you to go into the same profession?
Absolutely, absolutely. In the Filipino culture, the system of determining what career or pathway children go into oftentimes is predetermined by the parents and family. So when my parents actually came to the United States in the mid-1960s, had us educated within the American United States educational system, we were pretty much exposed to opportunities like liberal arts, etc. But I think having the exposure to having my mom as a family physician, general practitioner, as long as I can remember, really helped shape what I wanted to do when I was growing up. And I'm not necessarily saying that I wanted to be a family physician from the get-go, but I knew that I wanted to help serve people in the way that my mom did.
What do you remember and recall about the doctors you had growing up?
Interestingly, a lot of the physicians that I had were personal friends, personal family friends, and they were general practice, pediatricians, family physicians, and then general internists as I got older. And I would say the characteristics that I remember the most was that these individuals happened to be Filipinos also, because we were part of a network of Filipino physician families, and they were very caring and supportive and very concerned and assuring that we were integrating well into the American community and the education, and recognizing that dual identity, even though we were actually born here, was something that the first generation of immigrants from the Philippines actually paid attention to. And so I think it was interesting that instead of just the usual wellness exams of measuring my height and weight, they had that additional social concern of asking, how are things going at school? How are relationships going? And do you feel that things are going smoothly in terms of building friendships and having the teacher support you, guide you, identify your strengths? So,
right. A dual role.
Yes, yes.
You got a degree in psychology and a minor in biology and economics from the University of Virginia.
Yes.
Why psychology?
I was very interested in what made people behave the way they did, or made decisions the way they did, or acted the way they did. And of all the different classes that I took initially in my first year there at UVA, I gravitated towards a lot of the insight and the theories and the concepts that psychology was leading to. And I'm actually glad that I went that route, because fast forward to medical school and then to family medicine, in primary care, a large proportion of what we see in the office actually is influenced by psychological issues and transition issues and coping mechanisms. So for me to have the insight to pay attention to what might be going on behind the symptoms or what might be going on in their personal, professional lives, I think that helped me be a better clinician throughout the years and has helped me become a better person to be sensitive to really address issues. I believe that having my psychology degree allowed me to have a very strong foundation to give me the insight to be a better clinician and now an educator.
And when you went to undergraduate at University of Virginia, were your mind was, I will become a doctor, or were you sort of kind of testing out some other disciplines at that stage of your life?
I appreciate that question, and I'm laughing because initially I did have my goal of becoming a physician within my first semester there, but as I pursued a passion that I had in high school, which was being a cheerleader, I was one of 2 first-year students that was selected to be on the junior varsity squad at UVA.
Congratulations.
Thank you very much. And I tell you, I think after the first semester, I really thought, instead of being a physician, that I was going to pursue a career to be a professional cheerleader. And you can imagine my parents'
yes, I'm
reaction.
imagining that right now.
So I did go to UVA with the intention of pursuing medicine, but recognizing that there was this whole other world of other professions and activities. I think being a cheerleader exposed me to other options. But again, very interestingly, as I reflect back, and fast forward to even what I'm doing today, every step along the way, I feel as though I have pursued my passion as a cheerleader. So as a physician in practice for 20 years, I was a cheerleader for all my patients that I took care of within the hospital, within the community, in my roles of advocacy through all the medical organizations that I'm sure you saw in my history.
Yeah.
I was an advocate for the patients that I was serving, advocate for the physicians I was representing, and then certainly with my bigger administrative role, I was advocating for all people, in the Commonwealth of Virginia.
Right.
And now I'm advocating for the health of the public and generations of healthcare providers in the future. So I smile because I think I became what I intended to, which is a cheerleader. I just have different venues to be able to accomplish that.
You got your Doctor of Medicine in 1993 from Eastern Virginia Medical School.
I did.
What are some things that medical students can't learn in the classroom and can really only learn by being in a hospital or in a doctor's office with actual patients?
Yes, or in the community or any type of clinical setting addressing people. I would say the biggest issues that cannot be gleaned just by reading about it is developing empathy and to foster the compassion and care that is within them. I think every student that comes to EVMS, whether it's to become a physician as a medical student or any of our multiple health professionals like Masters of Public Health, physician assistants, surgical assistants, art therapists, etc., I believe they come to the healthcare field because they truly have a desire to help and serve, and because they have that desire to care for people in very unique and special ways. But once they actually sit next to a person who is homeless, until they actually sit down and get to examine, actually break that little bit of a personal space barrier and recognize that it takes gentleness, caring, and compassionate trust building to be able to have another person allow them to enter that personal space for truly helpful reasons. I think that's something that students realize, that when they get their training at EVMS, we put particular emphasis on building, fostering, and continuing the desire, motivation, and compassion that they came to the medical school with.
You completed your family medicine training at the Riverside Family Medicine Residency in Newport News, Virginia. How did you decide on family medicine as opposed to sports medicine or surgery or nursing? Why family medicine?
Yeah. So the biggest influence, I would say, was experiencing family medicine through my mom's eyes.
Yeah.
What helped me even further shape my choice was when I went on several medical missions. So here in Hampton Roads, in fact, particularly in Norfolk, we have several humanitarian organizations that have a presence internationally. So Operation Smile and Physicians for Peace, in particular, during my time at EVMS, were great partners. And with both of those organizations, I was able to participate in several capacities. Logistics, definitely, helping facilitate teams, helping participate in the screening ahead of time, prioritizing which of the hundreds and sometimes thousands of people within the country traveled to the sites where we were going to do, the medical mission, triage how many we could actually take care of. Then I actually participated in the operations. So I was participating as an assistant to the anesthesiologist. I was an assistant to the plastic and general surgeons and assistants to the nurses. Okay, so with that experience, I was exposed to pediatrics, general surgery, plastic surgery, anesthesia, and of course, internal medicine, family medicine. So it made me realize that, oh my gosh, there is so much to learn about it. Exactly. But then I think what made me start to realize, okay, as I reflected on that experience or experiences that opened my mind and made me realize that I have my personal strengths, skills, and capacity, and which ones actually resonate with me and come to me the easiest, it came to really the relationship building and continuum of care. So I realized, there are personalities that like things black and white, that like to have immediate gratification, and they are the ones who pursue surgery, OBGYN, etc.
It's broken, and then I fix
it. Fix it, exactly. Broken. There's a solution, exactly, and it's immediate gratification. Yes. Then there are those who really like higher paced, okay, so emergency medicine, anesthesia, really high risk, high pace, high stress. And then there are those specialties like primary care, family medicine, pediatrics for sure, internal medicine, general internal medicine, and then elements of OBGYN, where it takes special personalities to truly listen and to be empathetic. So after all that, I decided, I liked a lot of everything, but I think family medicine is where I want to be.
You were fortunate to get that exposure.
Yes.
You were in private practice for 20 years at
Correct.
Romero Family Practice.
Correct.
What do you miss about your private practice?
I miss the direct patient interactions. I was fortunate in that my mom took care of patients for about 35 years, and I overlapped with her, so I practiced with her as my partner, as my mentor, for 15 years, and my dad was our office manager. So it was truly our family delivering family medicine to our patients, to our practice, to our community. And so there are patients who knew me pretty much all my life, and they didn't really know what to call me. My mom was Dr. Romero, and I was somebody else. Exactly. But I miss, it's been about a year since I last saw patients, and what I miss the most is that intimate, special time with the patients to really try to allow them to share what's really pressing in their heart, in their minds, or in their bodies, that in a rushed world, when there may not be another venue for them to share that and to be evaluated, to have a better life, I really miss that opportunity.
What, in your experience, are the root causes of illness?
It's an awesome question. I would say there are, of course, probably a tremendous number of factors. Okay, so just illness in general due to regular aging and regular life. Okay, so as people get older, naturally our bodies change and shift and evolve. And just by simple genetic predisposition, couple that with behaviors that we know can impact health and wellness. So smoking, alcohol use, exercise or lack thereof. And we're learning about all these even more significant issues beyond healthcare delivery and genetics, and those are what we address as the social determinants of health. So we're recognizing that education level, the environment or housing, income level, all can impact the health and wellness of an individual or can be impacted by the health. So illness is when someone has a condition of being less healthy, or put another way, that they are not well. So now as we're looking at what are the factors that could lead to illness, again, it depends if it's true physical illness that could have been prevented, like, a broken ankle.
Right.
Roller skating,
yes,
or doing high-risk behaviors. But then if it's a condition like cancer or a chronic disease like diabetes, hypertension, again, in certain people, certain families, and certain populations, it can be prevented. But again, if it's a predisposed genetic condition that runs in the family, it's not a matter of if someone's going to develop those conditions. It's a matter of when.
What constitutes health in America? And is what constitutes health in America the same things that constitute health in other countries?
Ooh, good question. Good question. So health in America can be defined as beyond just freedom from illness or disease. Health, as it's being defined now, is having the optimal ability to stay well and feel well and be well. So when we're talking about health equity for everyone, so say, for example, if an individual is 20 years old, they're athletic, they're eating well, they have good relationships, they've got a steady job, they have been able to go through school, they've got good environmental, social, exactly, then they are a healthy and well individual. Now, if that individual were to develop, say, asthma, and they were to have medication and they were aware of a plan to help keep them from getting a flare-up, or if they knew that if they were smoking, that they would stop smoking, if they lived in an area that had a lot of mold and mildew or unclean air, they would address those issues with air filters or changing the environment somehow by moving. It's someone who has a condition or disease, but they've controlled it. So I would say that those individuals are healthy and well, but controlled with their medical conditions.
Okay.
As far as health and wellness is defined in other countries, I would also say, I think the definition of health and wellness is relatively the same when we're comparing what makes someone as healthy and well as possible. I think what differs is the delivery system. And as we see with our complicated, advanced medical system, we don't have the outcomes that we'd like, and we're probably spending the most compared to other countries. So when we're looking at the result of healthcare delivery connected to our outcomes, we have a significant amount of work that we could be doing. And again, we need to continue to partner together at all levels and across all aisles to try to have consistent, cost-effective, high-valued care.
How important is optimism and positivity in staying healthy, whether it's for a common cold or something more serious?
Absolutely. It's very significant. There are hormones that are related to causing a better and stronger immune system that are associated with people who have more positive, optimistic, and feeling supported and feeling loved. Contrary, when there are anxieties, stressors, and less positive outlooks on life, there's a clear connection that the immune system, healing processes, and just the ability to carry on is compromised because of that lack of support.
In January 2013, Governor Bob McDonnell named you as Virginia State Health Commissioner. How did you find out that you were going to be appointed as Virginia State Health Commissioner?
When my predecessor had resigned, Secretary Hazel reached out to me as one of several physicians that were being considered for that role. And so he reached out to me.
It was a phone call?
It was an initial phone call,
Okay.
yes. And it was while I was seeing patients in my office. It was quite surprising to have gotten that phone call. I initially declined just because I had so many other roles. And I initially had thought, since I had not served in government before and I had not had a true, what in my mind, a true background in public health, I initially said no. But Secretary Hazel came back to me another couple of times, and the more I realized that, having years of private practice in a mom and pop shop, having years with health policy advocacy, having years as a hospital administrator, that actually I was improving the health of the public through all those roles, and that perhaps I was qualified to serve in that role. And clearly at that time, once I started the role, it was probably one of the most professionally fulfilling and gratifying roles I've ever had.
You mentioned you replaced Dr. Karen Rimley, who
Yes.
resigned from the position
Yep.
following the passage of an abortion clinic regulations in 2012 that required doctors to perform an ultrasound on women before they have an abortion. This was a revised bill that originally forced women to have an invasive vaginal ultrasound, which set off protests from women's rights groups, made national headlines, and was referred to by many as state rape. These were treacherous waters that you stepped into. How did you
Yes.
navigate all of that?
I stayed close to Secretary Hazel, and I actually stayed close to Governor McDonnell. As the state health commissioner, agency head for the Virginia Department of Health, and the primary health advisor to the Board of Health, to the governor, to the secretary, I felt I had an alliance that I had to uphold with them. But I also tried to stay as true as possible to the people I was dedicated to serve, and recognize that taxpayers of Virginia were paying my salary, and I had to provide as much education as possible and try to do my due diligence to assure that whatever policies were being advocated for, particularly around women's health and other health-related issues, that I was trying to be their advocate and to try to delve into what were the main motivations behind a particular legislation and what were the balance of risks and benefits to any advocacy efforts that the administration was trying to uphold.
The Virginia
Yes.
Department of Health's mission is to promote and protect the health of all Virginians.
Yes.
Which segment of Virginia's population needs the most protecting?
I would say all. Granted, the most vulnerable are those who are suffering the most, particularly in areas that don't have the resources or the infrastructure, such as the rural environments within Virginia. And I think we need to constantly focus on how do we provide equal access to various services. So I think as we're trying to look at who are the most vulnerable and how do we help create a healthy Commonwealth, healthy Hampton Roads, healthy city, healthy family, of course we have to pay attention to the most vulnerable, those who do not have the education or who do not have the stable environments or do not have the incomes that lend to better outcomes. We need to equalize and establish a system that is equitable for everyone.
You've traveled in mobile medical units delivering medical assistance to people across the state. What are you and your staff experiencing on site at these medical units?
One of the first times I participated in that, to see the large number of patients that needed dental and oral care was just astounding, just absolutely astounding. And certainly from a primary care standpoint, looking at patients in that holistic, well view, if there are any problems or issues related to oral and dental health, it impacts, number one, just health outcomes overall. So if someone doesn't have teeth or they have teeth that have significant decay, it'll be difficult for them to chew, especially foods like meats or anything hard or crunchy. And so that immediately limits what they're able to eat. So like fresh vegetables and things along those lines, unless they prepare it a certain way, if they know how to prepare it or have access to it. But also when there is poor oral health or there's been no real instruction and education on how to take care of their teeth or how to take care of their mouth and to actually get the right nutrition. The mouth is really, particularly the gums, are a gateway for infections. And so when people are coming to the emergency room with fevers and uncontrolled sugars and other conditions, it's not surprising that many of them end up having infections, not just right there within their mouth and in their gums, but to see that sometimes they can develop infections within their bloodstream because of very poor dentition. So I think if I had to pick one thing that just really impressed me was the remarkable need and lack of access to stable oral and dental care.
What do you most often hear from the people you serve in these units? Like, what did they say to you?
They say, thank you for being here, even if we're not able to pull all of their teeth, or even if we're not able to give them, the dental implants like they need right there. Mm-hmm. The fact that the system is changing to provide some of those services, or at least there's time for us, medical students, physicians in training, and other health professionals to help provide the education about here's how nutrition will impact your health. Here's how using dental floss, focusing on kids and educating them. The families are so grateful. They are so incredibly grateful for healthcare professionals to take the time to participate on any of those missions, whether it's, through a van or in some of our remote clinics.
How has the acceptance of women in the laboratory, in the ER, in surgery, and in medicine in general changed during your career?
Oh, gosh, it has changed significantly. I would say even just with my mom and the time that she was completing her general medicine, family medicine training, there were very few women physicians, particularly in Virginia and the United States. And minority physicians, I would say, has definitely increased. So when we look at the number of applicants that are coming to medical school and other health professions, we are seeing that the number of women has actually increased. And so the result is definitely a tremendous broader representation of women and minority diverse women. So definitely I've seen that change from my medical school years, as well as through residency, and then definitely through the various specialties. So, for example, a lot of the surgical subspecialties, so urology and general surgery, orthopedic surgery, and now we're seeing that women are naturally part of those specialties as well.
The latest edition of the EVMS magazine features the cover story, Women in Science and Medicine, which comes out in November, and you are featured in that. How do you teach and help physicians learn to deliver bad news to their patients?
This is definitely a conversation that is being implemented several times throughout our curriculum at EVMS, even starting as early as first year, and recognizing that bad news is something that is part of life, but to recognize that the person on the receiving end of the bad news is a person with emotions, with expectations, whether the news is about themselves or news about a loved one. And so, at least personally, as I have tried to help guide other physicians, but certainly medical students and other healthcare professional students, how to deliver difficult news, I remind them that, number one, get as much of the facts that you can get prepared before the conversation, because there will be questions.
Sure.
Also, they need to stay in touch with their own humanity, and again, be empathetic and anticipate that if the shoe were on the other foot, or the roles were reversed and you were receiving that, how would you want to receive that type of news? And how body language speaks louder than actual words, and being mindful of the delivery, the softness of the voice, but being prepared, being direct, allowing time to process.
I kind of felt like you were delivering me some bad news right there. There were times about a generation ago when doctors would conceal information from their patients if they thought that that was in the patient's best interest. There were times when doctors didn't reveal that a patient's cancer was terminal. This kind of paternalism would be considered a breach of ethics now.
Yes.
Talk a little bit about ethics
Yes.
and the ethical principles of modern medicine.
Yes, I appreciate this question, and I think the conversation has changed because of the technology and aging issues.
Have
Yes.
advances in medical technology made it more difficult for doctors?
Yes, I would say yes. I would say yes. The idea of advancements in medicine and the technologies to prolong life, I think gives our society the mindset that we want our loved ones to live as long as they can. But I think that goes back to situations are different. So if it were a young person that were in a car accident, yes, we would want as much to be done because they have a higher expectation of living longer. But there are certain situations where we know as older persons are terminally ill, and we're looking at a continued decline in function, in the ability to get well, and certainly quality of life. However, we define that along with the patient and the family. That's why I believe it's so instrumental to start the conversation and then getting things documented. So when it really gets to that point, it's an expectation to say, this is where we go. And then just when it's time to pass, allow them to pass as peacefully and with integrity and dignity as much as possible.
One of the things I like about my doctor is he tells me what he would do if he were me.
Yes.
Why don't more doctors tell you what they would do if they were in your shoes?
Yeah, I think physicians now are balancing between that old mindset of paternalism versus a shared partnership and decision making. I like to offer all the options, and oftentimes they do ask, well, just tell me what to do.
Yes.
Okay. I think physicians want to be careful not to tell them what to do, because then if something goes wrong, or if the family member comes back and says, oh my gosh, you made the wrong decision, we don't want to be accountable.
Sure.
Many times, again, depending on what the situation is, whether it's getting a test or whether it's getting chemotherapy or whether it's getting immunization, there's a lot of information that's out there. And you figure if the patient is asking you the question, that just means there's a gap in really understanding what the risks and benefits might be.
Sure.
And I think that should guide physicians to say, and medical students to say, what additional education or information do you need that I can provide to help you?
What kind of patients do doctors make?
I would say it depends.
That's fine. I'm sure it does. Of course it does.
I think by and large, we're probably some of the more difficult patients, because some of us may know too much of what we know.
Sure.
But I would say on the other hand, I think we make good patients because we try to make it easier knowing what the person on the other side of the laptop is looking for.
Yes.
I think we're probably, just like we hope all patients are, more attuned to changes in symptoms and stressors, etc. If I had to choose, I think we make some of the more challenging patients.
I've just got a few more, Dr.
Sure. Okay.
When it comes to money and costs, there seems to be basically two camps of doctors. In one camp, we've got the corporate doctors, let's call them, who say we've got to be more efficient and operate more like a business, trying to cut out waste. And on the other camp, we have what are sometimes referred to as mission doctors, who are focused on what is in the best interest of the patient, not the hospital, not the doctors, or the pharmaceutical companies. Am I oversimplifying it?
No, I don't think you are. But I think there is an element of needing to balance between the two, because there's evidence that shows, particularly in Medicare information, that there is a significant amount of excessive waste and duplication and inefficient delivery of services and inappropriately administered testing and procedures. So in that vein, if we are doing the appropriate studies to evaluate utilization, we've got to get back to what is the most effective, cost-effective, high-valued care. But I'll say we want to also balance with, just because someone lives in Southwest Virginia does not mean they shouldn't be able to get the MRI of their brain because there's a risk of brain cancer. So there's truth definitely to both sides. And I think physicians who just want to focus on patient care they also need to be mindful of how much things cost. But likewise, even surgeons have to determine, okay, are these the best steps to pursue surgery versus waiting and seeing if there's another alternative way to treat a certain condition. Again, I think it's a conversation that probably could be neutralized a little bit further with data, and then focusing on evidence-based strategies and utilization information, and seeing where we are, where the disparities are, and see where we can come together.
I'm going to try for a yes or no.
Okay, sorry.
No.
I'm sorry.
No, don't be sorry.
Yeah. Okay.
Are Americans over-medicated? You don't have to give me a yes or no if you don't want to.
Okay, and just so you know, from a family physician standpoint, we immediately go through the spectrum of ages.
In general?
In general.
Americans, the American population?
Yes.
Okay, you can add on to that.
Yeah.
I'm not going to...
Yeah, I would say I believe, and some research studies have showed, that our society is more prone to want a fix by a pill as opposed to looking at other ways of addressing our issues, where physical therapy or group therapy or individualized psychotherapy, functional improvement could be a better way to improve an outcome versus taking a pill. I think we could be doing better as a society, recognizing that a pill may be convenient, but it may not be the best outcome. But I'd also say that there are, unfortunately, growing populations like those who are mentally, whether it's mildly or severely mentally ill, that are not getting medicated enough and not getting the services and support that they need. So that's why I was thinking both directions.
Over the last 20 years or so, there seems to me to be more and more pharmaceutical drugs for very specific types of ailments.
Yes.
And I guess my question is, what is behind this? Are we simply getting better at zeroing in on certain symptoms and illnesses? Or are these drugs just a way to make money off certain specific symptoms that used to be taken care of by one drug that tackled all or most of the symptoms?
Yeah. I would say it's a combination. So number one, I would say, yes, we are getting better at identifying truly very specific conditions. But I will also say that there's probably an element of marketing and business motives for pharmaceutical companies to be able to break out and identify a new market area that they can be successful in.
How much influence do pharmaceutical companies have on the day-to-day practices of doctors?
I would say much less than previously. I believe with some of the changes in federal legislation where pharmaceutical representatives can't provide logo type instruments or
like
materials.
pens and notepads, all those things.
Exactly.
Yeah.
I mean, granted, I don't think that really influenced my prescribing as much as the market research showed. But I would definitely say now, I don't think it has been, except for certain conditions like cancer, where if there are opportunities for new medications to be tried in trials, that physicians are trying to have access to those type of medications.
How much are doctors responsible for the current opioid epidemic?
I think they are one of the responsible parties in combination to so many other factors within society. So there's a history there that years ago there was a desire for accreditation of hospitals to address pain as a fifth vital sign, and that led nurses and everyone within the hospital to focus on pain, to ask about pain, and more importantly, to actually prescribe something for pain. So I think that particular movement was there. Then there was an introduction of OxyContin and other similar medications to the market that was initially presented as not addictive, but yet we know now that it is. And then this whole idea of avoidance of pain and the culture of pain, where I think patients now are choosing to have medication rather than deal with pain, and recognizing that there are different categories of pain. So cancer pain is, something that we hope no one ever suffers through, but they appropriately need medication to help ease their pain and hopefully eliminate it. After any kind of procedures, after any kind of accidents, there's an expectation for pain and reduction of pain. And then there's some chronic illnesses, chronic low back pain, neck pain, etc. I think we as a society have gotten to a point where it was an expectation that none of us want to suffer, none of us want to have pain. But I think what we are doing as a profession, and certainly as a society, is trying to address that culture of pain. What we want to be able to do is, number one, identify those patients who are at risk for addiction. Okay, and really, if that is an issue, address the addiction even before prescribing medication. And number two, identifying that there are so many strategies to address pain, but also to address the expectation of the patients, and to recognize that there are some conditions that the pain will never get down to zero, but rather we can help you get more functional and get you as active as you can be and back to your normal, abilities if we do this, this, and this. Definitely taking advantage of physical therapy, occupational therapy, and all the other massage therapy that will minimize the dependence of medication. There are generations of physicians that post-op or after a procedure tend to just write a specific amount. I think we're learning now that all professionals writing those medications need to be really reasonable and just anticipate that giving 60 pills post-operatively is not something that's necessary.
That's exactly what I was going to say. To me, it's simply almost a matter of a numbers game, that if you prescribe someone 40 pills, and if you take 2 pills a day or 1 pill a day, if you do anything 40 times in a row over 40 days, you are probably on the 41st day, if it's doing push-ups or watching a TV show or doing anything, you're going to want to and almost physically need to at that point to do that thing for the 41st and the 42nd and the 43rd day. So to me, it's sort of a numbers game. Like it's no wonder that people are...
Right. So number one, you're right. So we need to be doing better at limiting the number of pills, but also addressing their efforts to actually take pills back, okay, to keep them out of the house, that once you don't need them, there are different, like in Virginia Beach, there are police stations and fire stations that are actually doing their take-back days. And I think that's a simple, easy community intervention that if you're not using medications, even if they're blood pressure medicine, but definitely pain medications or anxiety pills that you're not using that are probably expired, bring them back. We'll help dispose of them.
If you give people recycle bins, more people will recycle, right?
Right.
All right, this is the final question. I would say that the majority of Americans who have doctors like them. What many Americans don't like is the system doctors are more or less forced to be a part of. If you had the ear and the vote of members of the Senate and the members of the House, and you had a minute to make the case, what would you say to them? What would be the one thing you would try to convince them that they need to do? What's the one thing they should focus on?
I would say invest in prevention and a system that connects outpatient to inpatient services as much as possible. The healthcare delivery system now is still reactive, and having patients who have illnesses and diseases get in and get treated, and they're getting the procedures that they need. But what we need to do is invest in the system of prevention and education in a prioritized way, not as a secondary priority, but as the main priority. And if we were to shift that, we would probably be in line in terms of delivery, reduction in costs, and reduction in mortality due to some of these chronic diseases like other countries are doing that are more efficient in the value of their care.
Dr. Cynthia Romero, thank you for coming on the show. It means a lot to me.
Andrew, it's an honor. Thank you.
This is Andrew Paul Cronin, and you've been listening to the Q&A with A.P.C. To hear archived episodes, visit QAAPC.com. For exclusive content, including upcoming shows, behind-the-scenes pictures, and more, follow the show on Instagram, Facebook, and Twitter at QAAPC. The executive producer of the Q&A with A.P.C. is Ben Riley. The music was arranged by Soup.